This was a study that compared about 900 patients who had bariatric surgery to approximately another 900 or so who underwent medical therapy. And the aims of the study were to compare complication rates in the two groups and also to compare resolution of comorbidities. The primary comorbidities being dyslipidemia, hypertension, and resolution of diabetes. And what the conclusion of the study was that the surgical group had a much higher resolution of those comorbidities than the medical group, and that was statistically significant. And it also showed that the surgical group had a higher complication of surgical complications in the medical group, which of course makes sense. Medical patients who don't have surgery typically won't have surgical complications. I think it is an important study. I think that one or two things that I found to be very strong was the large number of patients, the almost 6.5-year follow-up, and approximately about 100% follow-up of patients. So very long-term and strong numbers in follow-up. I think there are certain limitations of the study. Number one, the groups aren't similar in that the surgical patients and compared to the medical group, the surgical patients were typically younger and had a higher BMI, and that may therefore affect the outcomes that are seen in the trial. So I think that's one limitation. I think another limitation is it's difficult to compare postoperative complications in a group that never had surgery. So that really wouldn't be a fair comparison. Third, I believe that the surgical patients had a much higher resolution of diabetes, hypertension, dyslipidemia, and therefore you could then draw the inference that they would have a much greater likelihood of resolving or not developing many cardiometabolic or cardiovascular symptoms that go along with those comorbidities, and that wasn't looked at in the study. Also, there was no the study did not discuss any weight loss between the two groups, and so it would be nice to know what the absolute weight loss was and whether or not that also had an effect as to the outcomes of the trial. I think here at CHS we're uniquely positioned in that we offer both. We offer both medical therapy and surgical therapy in a center, and often in combination. So some patients who've had surgery will then go to the medical side and have combination therapy, and vice versa. Again, a limitation of this particular trial was that patients who were seen in the medical group and then went on to have surgery, that was an exclusionary criteria, so those patients weren't followed. I'd also like to say that the likelihood of complications in a well-established program like the one we have here from surgery is very low. And certainly I believe, as do many, that the risk from surgery far outweigh the improvements seen and reiterated in this particular trial.
Importantly, these authors compared a large population, over 8,000 patients who underwent laparoscopic sleeve gastrectomy, Roux-en-Y gastric bypass, and laparoscopic gastric band placement, and compared them to about 25,000 patients who received weight therapy from their primary care physicians, including behavior modification and dietary advice and counseling. The authors found in this study an all-cause mortality benefit to patients who underwent bariatric surgery procedures compared to those who did not. Additionally, beyond the mortality benefit, these patients had durable health benefits, including improvements in their weight-related comorbidities and dependence on pharmaceutical therapy. This adds to the growing body of literature surrounding the benefit of bariatric surgery patients in the longer-term setting. These authors followed patients for over 4.5 years and were able to show that this durable benefit of mortality persists at that time point. This is an important piece of information in counseling our patients and educating our colleagues in the need for early referral of patients who may qualify for bariatric surgery procedures. The potential health and mortality benefits to these patients are now even clearer after the distribution of this study, and is something really important to bring to the table when having conversations about our patients' obesity and obesity-related comorbidities. This is an important piece of information that we as providers now have to suggest that these surgeries are meaningful and beneficial to our patients.